Okay, Kasra, welcome our seminar, and thank you for your participation. Today, I have the presentation, the PhD student, Karas, from Stanford University. Today presented the title, your presentation is Transcranial Ultrasound Simulation, Optimization Simulation Paradigm and Modulation of the Neuron. You can start when you want, Carl. You have approximately 45 minutes, the presentation.
Sure, sounds great. Thank you so much for inviting me. I am very good friends with Dr. Marcelo Rivas. When he asked me to give this talk, I mean, I could not say no. And so I'm really happy to have this opportunity to share with you the work I did during the course of my PhD. By the way, how's the audio quality? Can you hear me well? Okay, perfect.
Yeah, so I can hear you perfectly.
Yeah, it's okay.
Okay, great. So the title of my talk is Transcranial Ultrasound Stimulation. I'll explain what that is in detail. And I'll be covering the work I did in optimizing the simulation paradigms and modulation of the neurons. So what we do in transcranial ultrasound stimulation is that we place an ultrasound transducer on patient's scalp, and then we send sound beams to an intended target deep within the brain with the intention of modulating the neuronal activity or even ablating or burning part of the tissue. Now, what happens under the hood is a little more complicated. Just okay this out. So if you look under the hood, if you will, we have the skull that separates the brain from the outside world. So if you want to be able to sonicate the brain, we have to really have these sound waves pass through the skull, then enter the brain, and then intersect at the intended target. Now, if we were to place electrodes at that target, we would be recording something like this. Say in this example, we have 8 electrodes. Each of them are recording the action potential of one of the neurons. And we can observe, for example, say in electrode number 3, after we have sonicated, which is represented by that green band, after we turn the ultrasound on, you can see that the neuronal activity increases. So we have somehow stimulated those neurons. But if you look at, say, electrode number 2, the activity is repressed after we turn the ultrasound on. At this point, no one in the field really has a clear mapping, a clear function that maps the ultrasound input parameters to neuronal activity that we see in these electrodes. Every other week, papers come out that are contradicting one another. So if you want to be able to have a finer control over what sort of neural response we want to see for a given ultrasound parameter, we should probably want to first increase the spatial resolution at which we are interrogating the neurons, right? The second thing we would probably want to be able to do is to apply direction-specific forces, because there is some hypothesis in the field that neurons may respond differently or selectively to forces given their directions. The second thing is the third thing is that we should probably have a better understanding of the strain profile, because again, there is some research showing that it could be the case that neurons will respond selectively to positive strain versus negative strain. And lastly, it would be nice if you could apply selective pressures. What I mean by that is if we turn a transducer on and the pressure waves are arriving, you're going to have positive and negative polarities applying at the target with equal amounts. But what if we could apply only positive pressure or only negative pressure? We do know that, for example, piezo electric ion channels, piezo 2 ion channels, respond selectively to only positive pressures and not negative pressures. That's an example of how we think that there could be some neural subpopulations that will have selective response. So in the first part of my talk, I will cover the work I had done in these 4 fronts. The next thing is when I showed this animation of sound beams going through the skull and then through the brain and intersecting at the focus, I showed this like neat passage. In reality, that's not what happens, because skull and the brain matter have very different physical properties when it comes to propagation of sound. For example, speed of sound in the skull on average is around 3,000 meters per second, whereas in the brain it's about 1,500. And so very similar to how when light beam passes through media with different physical properties, it beams and bends from its normal, it aberrates and bends from its normal path. The same thing happens here. So what we have to do is that we have to account for those phase aberrations. So what we would do, for example, is if we look at this animation here, if we have, let's say, 100 transducer elements lined up on top, and we have the skull CT, we would have to account for those aberrations and delay the firing of some of these transducers so that we have that constructive interference at the focus. So in this example, you will see that the elements in the center fired last, the elements outside fired first because they have a longer distance to the target, so that we could have this constructive interference at the focus and sonicate a particular target. Now, the way we do this is we use physics-informed simulation software. And as all of you know, they have an inherent trade-off between efficiency and accuracy. If we increase the accuracy, efficiency goes down and vice versa. So we would like to be able to increase the accuracy of these simulations without really sacrificing any efficiency. So in the second part of my talk, I'll explain the work that we have done in improving both efficiency and accuracy using deep learning. So let's first talk about increasing spatial resolution. The first idea that may come to mind is let's just increase the frequency at which we are sonicating with these transducers, right? Because if we increase frequency, we have shorter wavelengths, and so we should be able to interrogate the brain at a much finer spatial resolution. But the problem in our scenario is that we also deal with a lot of attenuation. I mean, there are other issues. For example, if we increase the frequency, aberrative effects are worsened. We also have much worse skull heating issues with higher frequencies. But the most obvious thing is that we have to deal with attenuation. In this simulation, I'm showing the effect of attenuation as a function of depth and frequency. Each of these traces show the attenuation for different depth. So let's just stay focused on the gray trace, which is the first one from the bottom. That trace represents the normalized power deposition as a function of frequency at an 8 centimeter depth away from the transducer surface. So that would take us roughly to the geometric center of the brain. Note that if we keep increasing the frequency, we are going to minimize the normalized power deposition until, say, after 3 megahertz or 4 megahertz, we are depositing no energy. Almost everything is either attenuated or reflected or scattered or just absorbed in the brain matter. For, let's say, this 8 centimeter depth, something about 500, 550 kilohertz appears to be optimum. So again, increasing the frequency alone is not the solution. The solution really lies in the physics of the transducers themselves. In the top panel, where I'm showing the normalized max pressure, this is just the normalized maximum pressure profile for a single transducer. The inset in the upper left shows the schematics of where the transducer is positioned and the direction to which it's sonicating. If we take a cross-section along the axial dimension of this transducer, you will see that the axial pressure profile is pretty broad. When you look at this full width at half maximum, it's pretty broad. But then if you take another cross-section along the lateral dimension, and we look at the lateral pressure profile, in comparison to the axial pressure profile, it has a much narrower and sharper full width at half maximum. So now the question is, how can we leverage this distinction between the axial beam profile and the lateral beam profile and be able to optimize the spatial resolution of the transducer? And the answer is use 2 transducers. But how do we position them? In panel A, I have placed transducers A and B in front of one another. When you have 2 transducers in that configuration, which we refer to as the anti-parallel setup, you're essentially having the 2 broad axial beam profiles superimpose one another, and your resultant beam profile, the superposition, is also broad. You really gain nothing in terms of spatial resolution. Whereas in panel B, where we place the transducers at 90-degree angles, which we refer to as the orthogonal superposition, you are having the lateral beam profile of one transducer superimposed with the axial beam profile of the other transducer, and vice versa. In effect, you're essentially having the sharp lateral beam profile trim the broad axial beam profile, and the resultant superposition has a much sharper spatial resolution. In fact, when we tested out several configurations, we realized that the 90-degree arrangement gives you the optimal spatial resolution. In this simulation, I'm starting off with 2 transducers that are at 180 degrees, and I keep reducing the angle down to 90 degrees. And we observe that at 90 degrees, we get the optimum target volume. The other thing I should mention is that even though the optimum angle is 90 degrees, the setup has a good tolerance. Even if you deviate by several degrees, you can still get a nice tight focal spot. For instance, in these simulations, I was driving my transducers at 1 megahertz. And I noticed that even if I deviate by about 16 degrees, say if I'm at like 75 or 80 degrees rather than 90 degrees, I'm still able to get sub-cubic millimeter target volumes out of this setup. Let's be more specific, and I'll share some simulations. So here I'm showing the pressure profiles where I use F1 number transducers. So I have these single element transducers with 30 millimeter aperture and 30 millimeter radius of curvature, and their center frequency is at 1 megahertz. In panel A, I am just running a single transducer. You can see in the lower left-hand inset where the transducer is pointing. And in the upper left hand corner of that panel, I'm showing the volume at full width at half maximum of intensity. So you can see for a single transducer of these specifications that is running at 1 megahertz, I have about 10 cubic millimeters of target volume. In panel B, I have placed 2 transducers facing one another, the anti-parallel setup. And you note that, I mean, there are some interesting properties that I'm going to talk about later. For example, we are generating standing waves that we are hoping are going to be beneficial. But you don't really gain anything in terms of spatial resolution. You still get the same roughly 9.5, 10 cubic millimeters in terms of target volume. But in panel C, when we place them at 90-degree angles, all of a sudden you have a 40-fold gain in your spatial resolution, and we are reaching sub-cubic millimeters, 0.24 cubic millimeters, in this case, in terms of target volume. So it was interesting for us to see that by just this simple rearrangement of the 2 transducers and changing nothing else, we were able to reach sub-cubic millimeters at 1 megahertz transducers. 1 megahertz frequency, sorry. The next thing is application of direction-specific forces. Before I talk about how we are reaching at these direction-specific forces, I would like to present the equation that we use for this. I have to be honest, when I was studying the literature, I saw so many different ways of deriving the acoustic radiation force in focused ultrasound. The starting assumptions are sometimes very different, and the final formula they come up with are quite different as well, different from one another. The one that I liked personally was this one for 2 reasons. One is when I use this to simulate the acoustic radiation force, what we get in simulation is very similar to what we see in experiments. And the second thing is all the variables that are used in this formula are pretty easy for us to obtain. For example, if we are using K-wave, which is a commonly used simulation software for focused ultrasound, we can easily get the particle velocities, density, sound wave, and the pressure at any point in space to be able to simulate the acoustic radiation force. Now, if we use this formalism, let's say to compute the acoustic radiation force in the axial direction, this is the field that we simulate. In the background, I have the pressure field. And on top of that, I have positioned or placed the quiver plot for the force vectors. And you can see the force vectors are converging. They are sort of parallel at the focus. They peak at the focus, and they're almost always pushing away from the transducer surface, right? Which is expected. You turn the transducer on, there's a gradient, so the forces need to be pushing away. But then there's another level of simplifying assumption that people use commonly in the field, which is referred to as the quasi-planar wave assumption, which says, just ignore these first 2 terms, which is referred to as the mean Eulerian excess pressure. But if we do that, I mean, we have highly, focused transducers, then the field is going to be quite wrong. In this case, you can see that the Y components of these black arrows, which represent your acoustic radiation force, are pretty long, as if like you have a transducer on top and a transducer at the bottom, which really defies intuition. So this is not correct. I would say if someone wanted to use this formalism, the quasi-planar wave assumption, to make the math maybe easier, you could probably use it when your curvature is minimal, maybe in the far field of the transducer, but I definitely would not recommend using this if you have a highly focused transducer. And the next level of simplifying assumptions that is unfortunately common in the field is to say you have purely planar waves. So in this case, if you are assuming the waves are traveling along the x-axis, not only do you ignore your mean Hungarian excess pressure, but any term that has a y component in it or z component if you were in 3D, you have to ignore those. But then when you do that, all you're left with is pretty much just a gradient. And your force field looks even more erroneous. In this case, the focus is at about 30 millimeters. Note that in the region between, say, 20 to 30 millimeters, your force vectors are pointing to the left towards a transducer surface, as though there's some attractive forces towards the transducer, which is definitely wrong, and that's not what we see in practice. So for all these reasons, I just wanted to highlight that we ended up using the complete form for acoustic radiation force. So now that we have presented what formula we used for this, let's take a look at what these force fields look like for the case of a single transducer, anti-parallel transducers, and pair of orthogonal transducers. In panel A, I'm showing the case for a single transducer. The inset shows you the direction of the transducer, so the transducer is pointing from your left to your right. Again, as expected, you have these unidirectional force vectors that are peaking at about the focus, and they taper off as you move away from the focus. And it's pretty broad. In panel B, where we have the anti-parallel setup, we notice something very interesting, that these acoustic radiation force fields follow the standing wave pattern, that and at the nodes, we have these forces that are pulling apart from one another. So if you have neural population there, you're essentially tugging on the neurons. And at the antinodes, we have these forces that are convergent. They're pinching your target. So that's actually a neat setup. This will give us the opportunity to study the selective response of the neurons to being pulled or being pinched under defective acoustic radiation force. The one problem is that it's pretty broad, right? For, again, these small transducers that I'm simulating, this is a 2 by 10 millimeter field over which the forces are being applied. But if we place the transducers at 90 degrees, we get essentially the best of both worlds. On the one hand, we are able to apply these direction-specific forces. So if I zoom in, you will see that at the focus, we are again pinching at the target, or we have these acoustic radiation force sinks, if you will, the forces that are convergent. And immediately on either side of the focus, we have forces that are divergent. We have the acoustic radiation force sources, if you will. But at the same time, these are applied in a 2 by 2 millimeter region rather than, 4 by 4 millimeter region rather than a 4 by 10 millimeter region. So we get, again, the best of both worlds. We wanted to corroborate this with experimental setup. So what our collaborator did was they placed 2 transducers. Each of them were elevated from the surface by 45 degrees. So with one another, with respect to one another, they formed a 90-degree angle. And then they suspended glass beads, 50 micron glass beads in water, and they sonicated those. And what they observed was exactly what we were seeing in simulation. So these shiny particles that you see, these are 50 micron glass beads. They're suspended in water. And each of these transducers is being driven at 1 megahertz. And the pulse duration is 100 milliseconds. One thing I should emphasize is that you won't see this pulsing effect if your transducer is turned on and left on, because acoustic radiation force is a net effect. You're integrating out the temporal aspect of it. The only reason you see this pulsing effect is because this collaborator is turning the transducers on and off every for 100 milliseconds at a time. So this corroborated what we were seeing for acoustic radiation force. The next thing is, I mentioned that we have to have a better understanding of strain profiles. And this part gets actually pretty tricky. I think first I should talk about how we compute strain for this. If we have a simple elastic rod and we want to compute strain for that, let's say if we have stretched it by some delta L length, it's very easy, right? To compute strain, we just take the ratio of that deformation, delta L, over the original length, which was L. But when we are dealing with biological tissue, it's a little more complicated, not too much, but it's a little more complicated because we don't really have a good sense of what the unperturbed original length of the tissue was in order for us to compute this kind of a ratio. So we decided to work with the Green-Lagrange strain tensor in this problem. Each of the U terms that you see, U sub I or U sub J, those are displacements. X sub I and X sub J are the directions in space over which we take the gradient. And the two terms to the right, the repeated indices in K, follow Einstein's summation. But in our case, because the deformations were really small, their gradients were even smaller. And so those two terms, when we multiply them, they are negligible. They are like 10 to the power of negative 16 or something. So we completely ignored those two, the nonlinear term in the end, actually. So to have the displacement and to take the gradient of it is the easy part. The question is, where do these displacements come from? What should we place in for like the variable u in this case? And when we thought more about this problem, we realized there are actually two different sources for displacement. One of them is the micro-level displacement due to the oscillations of the particles. Let me show you what I mean by that. In this case, I'm going to show you a simulation where I have a transducer that is placed on the left of the screen and is pointing to the right. And I want you to please focus on that red particle. And note how, as I turn the transducer on and the particles start oscillating, this red particle will oscillate at about the same axis that is, aligned with those green arrows. So you have this oscillation on a micro level that is about the original or equilibrium position of the particle, the red particle that you're seeing here. So we refer to this as displacement, micro-level displacement due to the particle motion. There's another displacement that is on macro level, if you will, that is due to the effect of acoustic radiation force, which causes a tissue level displacement. In this animation, I have purposefully turned off the effect of particle oscillation so that we can stay focused on acoustic radiation force. If I turn the transducer on, note that over time, as force reaches steady state, the particles are drifting away from the transducer, and they're bunching up away from the transducer, away from the target, which again is expected. If you had some sort of biological tissue here and you have turned on the transducer, this is the effect you would see. Note to the left of the green arrows, you're stretching the tissue because that's where the transducer is located. And to the right of the green arrows, you're actually bunching up the tissue. The particles are getting shrunk together. In reality, obviously, we have both of these occurring together. So if we put them together and we turn the transducer on, note that you're going to have this oscillatory effect on individual particles, but also the particles being about their equilibrium position, but then they will be drifted away to a new axis, and they will be oscillating about new axis. So the question for us was, which of these sources is going to be the dominant one? Should we look at the strain due to the particle motion effects on the micro level, or should we look at the strain due to acoustic radiation force on the macro level? And we're presenting the maps. The maps look very different. If you look at the strain due to particle motion, I think there are two things that are important that we notice. One is that the strain due to particle motion peaks at the focus. That's panel A. You can see that strain reaches its maximum value at about 30 millimeters, which is the focus, and it tapers off. The second thing is that the normal component, the axial normal component of strain, dominates the other forms. Note, for example, in panel C, we are showing the shear strain, and it's negligible compared to the normal strain. Please hold that thought and compare that to strain due to acoustic radiation force. When we look at the macro level strain, the one interesting thing is that the dominant one is now the shear strain, which is shown in panel C. And the second interesting point is that strain at exactly the focus remains 0. And this is very important, I think, to consider, because sometimes in experiments, I have been to talks where people show how they were trying to do like single cell recordings of neurons under the effect of focused ultrasound. And they were noticing that they are seeing higher activity around the focus rather than at the focus. And their immediate assumption was that the transducer is misaligned. They have to move it around because they expect the highest activity at the focus. But maybe it is in fact the case that these neurons are responding to this strain due to acoustic radiation force, which is maximal around the focus and 0 at the focus. These are sort of like the things that we have to consider if we are trying to come up with this detailed map, detailed function that maps ultrasound input parameters to neural response. Now, I had done these simulations for each of the 3 different configurations, the single transducer, anti-parallel setup, and orthogonal setup. But instead of showing each of them separately, I put them together in one figure to make it easier for all of us. Let me first explain what's the arrangement here. Each column represents one of the configurations. So on the left, we have the single configuration, in the middle, the anti-parallel configuration, and to the right, the orthogonal configuration. The top row is only the particle motion strain, and the bottom row is only the acoustic radiation force strain. And for each case, I have picked out the dominant effect so that we can compare these scenarios against one another. For example, in the top row, we see that the strain due to particle motion for anti-parallel setup dominates the other two. And that is expected because in the anti-parallel setup, we have the transducers facing each other, and the pressure components from the two transducers just add up. If you have P from one transducer, P from another transducer, you have 2P added up. So the range of motion for the particles is much larger in that case. Whereas when you have the two transducers in orthogonal setup and the pressures are coming at each other at 90-degree angle, what you effectively have is cosine 45 of each of those P. So you have root 2 over 2P plus root 2 over 2P, you have root 2P. So you don't have the exact 2P added. That is explainable. And for the bottom row, or something else I should mention, in the top row, when we are thinking of the strain due to particle motion, the dominant one across the board is the normal component of strain. But then when we look in the bottom row, we note that, for example, for a single transducer, it is the shear strain that was dominant compared to the other forms. Whereas for using a pair of transducers, either in the case of orthogonal setup or the anti-parallel setup, it is the normal strain again that dominates. And once again, it is the anti-parallel setup that in terms of the actual magnitude dominates the other two configurations. That is also explainable. If you have like two transducers that are facing each other, you're going to be sandwiching the tissue from either side. And it is expected that you will expect that you should see the highest amount of shearing or strain in your tissue. And the last thing for this first part of the talk is to show our idea of how we can apply selective pressures. To simplify the concept, I will share this like schematics. The idea is actually pretty simple. I mentioned that if you have a single transducer, you turn it on and you're sonicating, say, a particular target, because waves are going to have positive and negative lobes that have equal amounts, your target is going to experience a positive pressure and the countervailing negative pressure, and vice versa. It's just going to continue going back and forth. But we want to be able to apply dominant positive pressures or dominant negative pressures. How do we do that? The idea came about with this schematics. Suppose you have two transducers at 90 degrees, transducer 1 and transducer 2. What you have to do is to generate single cycle pulses, make sure that the pulse from transducer 1 is inverted with respect to transducer 2. What I mean by that is if the pulse from transducer 1 is positive negative, make sure that the pulse coming out of transducer 2 is negative positive. They are flips of one another. And then delay the pulse from, let's say, transducer 2 by half a period. When you do that, what happens is that at time tau, when the negative lobe from transducer 1 arrives at the target, denoted by that dashed box, there is no other pulse from transducer 2 to superimpose with. Some delta t time later, at time tau plus delta t, now you have the positive lobes of the pulses from the two transducers superimposing one another, giving rise to 2 times P for you. So you have a dominant positive pressure. And then 2 delta t times later, these pulses wash away from one another, and you don't have any more constructive superposition. Let me show you an actual simulation. In simulations, real simulations, the scenario is a little more complicated because you have the curvature to the transducers, to the beams that are coming out of the transducers. So this simple a priori knowledge that I'm going to invert the pulse and delay it by half a period doesn't quite work. You have to run a pretty basic, simple, iterative algorithm and just go through a for loop to identify which time delay and which inversion is going to give you the maximum overlap. And in this particular case, where we were generating tricycle pulses rather than single cycle from each of the transducers, we were able to generate a peak positive pressure at the focus that was about 1.54 times greater than the peak negative pressure. And if we, again, modulate the actual amount of the pressure, we will be able to subject the neurons to only positive pressures that they experience and no other negative pressure. And vice versa, of course, if you flip the whole paradigm around, we can apply selective pressures that are like 1.54 times than the positive pressures. All of the points that I mentioned in greater detail are submitted in this paper. We actually just got the paper accepted last Friday to IEEE UFFC. Now, the second part of the talk is about phase aberration correction with high accuracy and high efficiency. Earlier, when I showed this animation and I mentioned how we have to apply phase delay so that we have that constructive interference at the focus, I didn't explain how it's done. One of the gold standard ways of doing this is time reversal. So the way that works is you take the CT scan of the brain, assume this gray semicircle that you're seeing is a CT, is a toy model, obviously, here. And you have the location of your elements. In this case, I have simulated 100 elements. You already know what's the target that you're trying to sonicate, right? That's what the red circle shows. This idea of time reversal that was introduced by Matthias Fink says, send the pulse in reverse from your intended target in simulation, of course, and then put your elements in receive mode. That way you can receive for each of the 100 elements the time at which the pulses arrived at that element. Then you can apply those time delays. Now this time put your elements in transmit mode and generate your sound beams. And you ought to be able to have this constructive interference at the focus. Once again, note that when I turned this animation on and ran it forward, the elements on the periphery turned on first. They fired first simply because they had a longer path to travel towards the intended focus, whereas the elements in the center fired last. If we do this, the problem is that because this is based on the physics of the problem, we are still tied down to that trade-off that I mentioned earlier, trade-off between efficiency and accuracy. If we want to improve efficiency here, for example, if you want to run this on a much finer spatial resolution, simulation runtime is going to be a lot longer. And vice versa, if you want to improve the simulation runtime, we have to reduce the accuracy of the simulation. So we are dealing with this trade-off. And to show you, and this is just a wrap-up of the steps. So we simulate the pulse in reverse, we record the time delays, and then we run it forward. To show you some quantitative values here, I want to show this table from a paper that my colleague had published. My friend Steve Garng, he was working on hybrid angular spectrum method. I won't go into the details of what that is, but that's yet another method for computing these phase aberration corrections. And he was comparing his method against a very simple method called ray tracing that this company Insightec uses. Insightec is a company that develops these semi-spherical helmet transducers that, in fact, we use at Stanford for patients that we want to sonicate them for treatment of essential tremor. But as I said, they use this very simple ray tracing algorithm. So my friend was showing that if he uses his more complex hybrid angular spectrum, in terms of the recovered pressure at the target, he can improve it on average by about 15 percentage points, which is actually a significant improvement. Also, most important than that probably is the positioning error, that his method was able to improve it by about 50%, take it down to 0.35 millimeters on average. But here's the catch. What took Insightec 2 seconds to run, it took Steve's algorithm 30 minutes. And the problem is no clinician is going to sit there for 30 minutes to wait for one round of the simulation to converge. They want something fast, ideally something fast and accurate at the same time. So how can we do that? The idea we had was, if we want to be able to do this fast, we have to essentially bypass all of these steps and have a method that helps us to go directly from the input to the output using deep learning. And the model, the algorithm that we came up with, we called it TUSNet. On a high level, TUSNet is a supervised learning model. It has, to train it, we had these input-output pairs. The input consisted of transducer elements. We had 80 elements in this simulation that are lined on top. We would take as input a slice of the CT of the patient's skull, and then we would delineate the target that we are trying to sonicate. That would be the input. And the output was obtained through simulation with K-Wave. Again, K-Wave is a software that is widely used in our field, and it's accepted as being used for ground truth. So we use that for ground truth. And on a high level, what TUSNet would give us were 3 mainly decoupled, for the most part, decoupled outputs. One of them was the absolute pressure, which was just a scalar value to help us rescale the normalized output and report the result in pascals. The second output was the phase vector, which is a vector of length 80 corresponding to the 80 elements that helps us apply the phase corrections for each element. And the third output is the pressure field, which is the normalized map of the pressure field that we have to use in conjunction with the absolute pressure to rescale it back. It will become more clear when I talk about the details of this. But after we conceptualize what we want to do with this TUSNet, we realized there's a big problem. We ended up using 180,000 training samples as like input-output pairs to be able to train TUSNet. But we realized that we do not have 180,000 skull CT segments. Actually, no lab that I know has these many skull CTs. So we decided to put this project on hold, the TUSNet project on hold, and instead think of developing a generative algorithm that will help us generate synthetic skull CTs that we could use to train TUSNet. And that was how the idea of SkullNet was born, SkullGAN was born. So SkullGAN, at the core of it, has these generative adversarial networks that after we have trained them, what we do is that each time around, we just sample from a 200-dimensional noise vector, that's the latent space, and it generates a skull CT for us, skull CT segment to be specific. Again, you can sample another noise vector, it can generate another skull CT for you. To train SkullGAN, we had access to 38 actual human skull CTs. And we took them at like 3 millimeter intervals. We took axial, sagittal, and coronal slices. And whenever they were vertical, we rotated them so that they are horizontal. We wanted to make sure everything is lined up parallel with the transducer elements. And in the end, we had these 128 pixel by 128 pixel inputs of skull CTs. And we ended up having about 2,400 of these. Maybe I'll mention some detail here. We could have taken the slices at much finer intervals rather than 3.1 millimeter. The one problem we faced was that if they are too close, there's some bias in the training data. And then the generative algorithm we train is incapable of producing diverse data sets if the training set is very close and very similar to each other. So that's why we came down with the 3.1 millimeter interval, and we had 2,414 samples. Now, before training SkullGAN, we did pre-training. Those of you in the audience who are familiar with machine learning know that this is just a standard method. And the idea is this. Once you have defined your model, when you start training, all of your weights, the parameters in your model, initialize randomly. They are meaningless. They have no meaning. And if you have a limited data set, such as us, we had 2,400 samples, that is really not sufficient to be able to train and fine-tune these parameters. What people do in the field is that if they have access to a much greater data set, first they try to pre-train on that data set. In our case, we pre-trained on this celebrity data set, Celeb A data set. It has 100,000 images of celebrities. And note, like 100,000 versus 2,400 that we have, there's a huge difference there. So once you pre-train on this like larger 100,000 data set, your weights, when you continue to train on your skull CTs, no longer initialize randomly. Now you have pre-trained on some actual images, and your kernels, your parameters have learned to, for example, pick out edges, corners, sharp contrasts, and so on. And that's going to really help with training and fine-tuning the model weights to your own data set. And that's what we did. We initially pre-trained on the Celeb A data set. You can see some of the generated samples in the lower left that we were able to generate of the celebrity. They are not perfect, but we were not aiming for perfect celebrity face generation. We just wanted to have the weights good enough. And then we continued training on the real skull CTs, and you can see some of the samples that SkullGAN generates. Here I'm displaying some real skull CTs in the top row. That's the training set, and the synthetic set that SkullGAN was generating at the bottom. Visually, if we look at if we inspect this visually, you can see that they look pretty realistic, but we have to obviously come up with quantitative metrics to confirm that they are, to the extent possible, indistinguishable from real ones. Some common metrics in the field are skull density ratio, mean intensity, and mean thickness. How are these computed? To compute skull density ratio, we took 32 rays down the skull segment, and for every ray, we would take the minimum density over the maximum density along the path of the ray and just average it out. We have 32 of those, we averaged over the 32. For mean intensity, you remove the background of the skull CT and just average out the intensity of the remaining voxels. And for mean thickness, you do something very similar to the skull density ratio. You take 32 rays, but this time, instead of taking the ratio of the minimum intensity over maximum, you just compute the widths. And so you can get like the mean thickness for them. Looking at how simple these metrics were, we already had a sense that these were not going to be sufficient to distinguish or differentiate between a synthetic skull CT and a real skull CT. It's just too simplistic. In fact, to prove our point that these were really simplistic, the methods that are common in the field, we generated these artificial sets of skulls. You can see these are toy models. We had a group that we called idealized ones. They look like a perfect skull. You have 3 layers and they're semicircular. And we also generated these unrealistic ones that are just like these squiggly shapes. And our intention was to show that even with these toy models, we can fool these radiological metrics. And sure enough, we were able to do that. So I'm showing the distributions of the samples we have generated. And I'm showing you the distributions for each of the 3 radiological metrics: skull density ratio, mean intensity, and mean thickness. The green distribution is for the training set, which is the real skull CT. The blue distribution is for synthetic set that SkullGAN generates. And the salmon or the pink one is the artificial set that you see at the bottom, the toy ones. You can see that almost in all of them, we are matching the real ones. In fact, if you look at the mean intensity in the center, we are also even able to mimic that bimodality of the distribution of the training set by our artificial set. So this was not sufficient. Then we said, maybe we should use T-distributed stochastic neighbor embedding, TSNE. In a very high level, the way TSNE works, you can think of it as a nonlinear dimensionality reduction. It looks at pairs of data points in your high dimensional space and tries to reconstruct another distribution in 2 or 3 dimensions so that we can visualize them for the same pair. And then iteratively, through KL divergence, it tries to optimize for what this lower dimensional distribution should be. First, we said, okay, let's define, because we need to have a way to quantitatively define each of the skulls that we have before we feed them into TSNE. So the first thing we did, we said, okay, let's define each skull with its corresponding radiological metric, which was skull density ratio, mean intensity, and mean thickness. We had 3,000 skulls. 1,000 of them were the real skulls. 1,000 were the synthetic ones that SkullGAN generated, and 1,000 were these, toy skulls, the unrealistic and idealized ones. When we applied TSNE to this, it could not separate anything, which further confirmed our hypothesis that these radiological metrics are really limiting. They don't really capture the necessary information in helping you distinguish between a real and a synthetic skull. Next, we said, instead of relying on these radiological features, let's just break free from them and define each skull with its voxels. So we had these 128 by 128 pixels for each skull. We just unrolled it. Now for each skull, we had this vector that was 16,384 pixels in length. And when we apply TSNE to this, it is able to separate the artificial set, which is composed of unrealistic and idealized one, from the synthetic and training set. There were 2 interesting things here. One is that not only was it able to separate the idealized or like artificial set from the rest, but also it separated the artificial set into 2 groups, one idealized one and the other one being the unrealistic one. But it still failed to separate the training set from the synthetic set, what we generated with SkullGAN. Okay, this was heartwarming, right? We were happy at this point that TSNE could not separate these 2, which suggests that what we were able to generate with SkullGAN was realistic enough. But again, we thought this may not be too definitive. The next thing we did, we actually just put together a quiz. We had a quiz where we had 25 synthetic skull segments, skull CT segments, and 25 real skull CT segments. And they were mixed. And we presented this quiz to 4 Stanford radiologists. We would present them one scan and ask them to tell us whether this is real or fake. That's all they had as options. They could not go back and readjust their answers. And also on purpose, we included 3 pairs of exact replicas within each set. And the idea there was we wanted to see on how many of these radiologists are going to change their answers. Are they going to like guess on those? This is an example. So you can see like the total time spent on the quiz. On average, this specific radiologist spent about 9 seconds in scrutinizing a fake sample before deciding what it was. They spent about 11 seconds on the real one. This is actually very good for us because we wanted to see that they spend about the same amount of time on fake ones and the real ones. And they switched, over those repeats that I talked about, they switched about 16%, 17% of the time, which was interesting. And the accuracy was 58%. As a reminder, the ideal accuracy, the theoretical optimum is 50%. If you can hit 50%, that means at that point, these radiologists are just guessing. The synthetic ones are so good that they're guessing. And if you look at the summary of their report, on average, the accuracy that we got was 60%, which again is pretty good. It will be very hard to hit a 50% theoretical optimum with these radiologists. And one last thing I'll say about SkullGAN before I switch over to TUSNet is that you may be wondering, what if SkullGAN is just memorizing its training set and regurgitating the same things every time it's generating something new? To prove that was not the case, what we did was we would generate one sample using SkullGAN. Let's look at the top row, sample 1. We would generate sample 1, then using 3 different metrics, MSE, mean squared error, SIFT, and ResNet 50, we would compare that generated sample against the entirety of 2,414 training set to find the closest counterparts. And we would observe to see which of those, if any, is a replica of what we have generated. And in none of these, for example, 5 samples that I'm showing you, we were generating something that was just an exact replica of the training set. They were quite different. I mean, on a high level, they are the same. You have skull, you have 3, the cortical layers and trabecular layer in the middle, but overall, they were quite different. And we have uploaded the details of this work to the archive. I probably have 5 to 6 minutes left. I'll try to make this point faster. So now that we have trained SkullGAN, and we were able to generate essentially indefinite number of, or infinite number of skull CTs, we were ready to go ahead and train TUSNet. What we did, we used SkullGAN. I'm talking about the panel A. We generated 3,222 synthetic skulls. I mentioned infinite. We could have generated infinite numbers, but we just didn't have the computational resources to handle that many. We settled with 3,200. And then for each of those, we simulated 56 different target points with K-wave, because again, K-wave was our ground truth, right, simulation here. So that gave us about 180,000 training samples, input-output pairs, which we used to train TUSNet. Let's see what TUSNet looks like once it's trained. Once it's trained, we feed it the input, which comprises the AD transducer elements, CT of the skull segment, and the intended target. And we get 3 different outputs. And I think this slide will clarify what those are. The first output is the 512 by 512 pressure field, phase-corrected pressure field. But this is normalized. Note that every value is between 0 and 1. We have to do this. Again, those of you who are doing machine learning, if you don't do this, we're going to have exploding gradients, and we are not going to be able to train the neural nets. But along with that, another output we get is the absolute pressure, which is a scalar value. This helps us rescale the normalized pressure field back into the units of Pascal so that someone, a physicist or a researcher who's using this, can actually make sense of the amount of pressure that they are depositing at the target. And then we can use what we have to compare against ground truth. And ground truth is the K-wave simulation done with time reversal that I explained earlier. So we can evaluate this. And there's a third output for TUSNet, which is the phase vector, right? Because remember, the other important thing is we want to be able to output a phase vector of time delays or phase corrections so that a technician can use those and derive the transducers with those phase corrections so that they can intersect the beams at the intended target. Once we had this vector of phase corrections, next we used those in K-wave. So note that we are using K-wave twice. Once is using it with time reversal so that we have the ground truth. The other time, we use K-wave with our phase aberration corrections to produce another pressure field. So that now we can evaluate these against one another. In the subsequent slides, when I show the evaluation results, you will notice that I'm going to show 2 different distributions. One will be the absolute pressure field, which is the output of the pressure field from TUSNet. And the other one will be the bottom one, the phase aberration correction, which is to show the accuracy of our phase aberration correction vector. So let's take a look at the top one, how it works. I'll make this quick, and I'm happy to talk about this more offline if anyone wanted to ask more questions. In a high level, we have these 5 cells within the encoding block and 5 cells within the decoding block. The important thing for each of these cells is that we have embedded long short-term memory units, LSTM units, with convolutional blocks. And in the encoding block, as expected, we are subsequently just like reducing the dimension of the input until we get this reduced embedding that presumably has into it baked the most relevant information about the input. And in the decoding block, we are doing it in reverse. We're building back up the size so that we can get that output of 512 by 512. And if you want to look at what this LSTM conv looks like, this is what each of those cells look like in detail. We take the input, we make 4 copies of it, and for each of those copies, we apply an LSTM in different directions, left to right, right to left, top to bottom, bottom to top. For each of those, we have the output cell, the output tensor, hidden tensor, and cell state. We concatenate those, reduce them so that the dimensions match for the next conv and LSTM cell. Then we do the same thing over and over. So we repeat this 5 times in the encoding block. We repeat the reverse of it 5 times in the decoding block until we get the output for the pressure field. And surprisingly, for the phase vector, it's much simpler. All we really have to do is to take the trained LSTM conv cell from the first input of the encoding block and just apply to it another series of convolutions and LSTMs, and we're able to get the vector of length 80 that represents the phase aberration corrections. Now, before I show the final results, let's just do a recap of how we got here. So first, we said we needed to have a lot of skull CTs, and we didn't have that many real ones. So we used the 38 real skull CTs that we had to train SkullGAN. And from SkullGAN, we were able to generate 3,200 synthetic skull CTs. For each of those, we simulated 56 different targets using K-wave. So that gave us these 180,000 ground truth simulations. We used the 180,000 ground truth simulations to train TUSNet, right? So at this point, up until this slide, TUSNet is now trained. Now it's time to look at how it performs on test cases. I would like to emphasize 2 things. One is that TUSNet is trained entirely on synthetic CTs. It has never seen real skull CTs. But during test time, we are giving it real skull CTs, 1,200 real skull CTs. And the second thing is these real skull CTs that we are going to test TUSNet on have never been seen by SkullGAN. These are completely disjoint sets that we are introducing. So this is an example, a visual comparison of what we are getting. Let's just look at the top row. On the left, I'm showing the input. What is the input that goes into TUSNet? It has the target, it has the skull CT segment, and it has the elements lined on top. The green band is the ground truth. This is what K-wave gives us using time reversal phase aberration correction. And the output to the right is the 2 outputs that I was talking about. One is the absolute pressure field that TUSNet produces. And the other one is the K-wave simulation on the phase aberration correction that TUSNet produces. And you can see we are also, as I mentioned, recording the values in terms of pascals rather than just using normalized values. Okay, now let's look at the evaluations. One evaluation metric that is important in our field is to look at the focal area overlap. So one simple metric is just to look at the full width at half maximum of the ellipses and just do a simple, subtraction over the ground truth value. And that's how we get these values. And you can see in terms of focal area overlap, we are at about 8% mean in both absolute pressure field and phase aberration correction. The other very common metric is intersection over union, which says, again, take the ellipsoid of your ground truth and the prediction, compute the intersection, divide over the union. And you want this value to be as close to 1 or 100% as possible. We don't necessarily like this value or this metric because it doesn't really take into account the orientations, because that's also important, how well your ground truth ellipsoid and your prediction are aligned with one another. But still, because it's common in the field, we use it. And again, we have like about 85, 86% average intersection over union. The next thing is positioning error. There are 2 metrics that are common. One is the modified Hausdorff distance. In the interest of time, I won't go over the details of it. I'm happy to talk about offline. But in terms of modified Hausdorff distance, we have 0.15 millimeter on average, or 0.18 millimeter on average for phase aberration correction error, which is really ideal. In terms of Euclidean distance for focal positioning error, it was interesting to see that the phase aberration correction is a little worse, but still it's great. It's 0.6 millimeters on average in terms of the focal positioning error. Next thing was pressure error. And there are two things we have to consider. One is the focal pressure error. Simply as the name suggests, we want to see how off we are in terms of estimating the pressure at the focus. And it's, again, pretty good. Average error for, let's say, the phase aberration correction is only 1.7%. And there's another metric that we have to look at, which is the peak pressure error. And this is important because it could be the case that our algorithm is off and the pressure, the maximum pressure that we are getting is actually not even at the focus. It's somewhere off focus. So we have to also look at what's the peak pressure, irrespective of whether it is at the focus or not. And the details of this work are in preparation for submission. Now, just to wrap it up, in summary, we talked about how we would like to be able to have a finer control over the recordings we are getting with electrodes under the effect of transcranial ultrasound stimulation. We mentioned how we could use 2 transducers in orthogonal setup so that we can optimize the spatial resolution. In terms of applying direction-specific forces, we saw how using orthogonal transducers allow us to impart those localized forces in a directional manner. And we described how we can have 2 different sources for particle displacement on micro level and macro level, and how we get different sets of strain out of each of those. And in terms of applying selective pressures, we discussed how we can use this inversion and delay approach to be able to apply pressure selective forces on the target. And in terms of the phase aberration correction with high accuracy and efficiency, we discussed how first we had to develop SkullGAN to be able to generate these realistic synthetic skulls that we can later use to train TUSNet, which is the algorithm that takes as input the skull CT, location of the elements, and the location of the target, and outputs both the phase-corrected pressure field and the vector of phase aberration corrections. And that's all. I'm so sorry that I went over time. I'm happy to take questions.
Okay, thanks, Karen. Very interesting your work. Very, very interesting. Okay, it's time the question. Any question? Let's see.
Hi, Humberto. Just a quick question. Any plan for a clinical trial?
So I will go back and explain that. That's a great question. In terms of the work we have done with TUSNet, we can't apply this to clinical trial just yet because everything I presented here is in 2 dimensions. And to be perfectly honest, as a research lab, we don't have the money to be able to train this for 3 dimensions because we would have to have GPUs. These were already trained on GPUs. I mean, it cost us about $30,000 to train TUSNet. We had 4 GPUs through Google Cloud Compute that we were using. So it's very expensive. And to be able to take this to clinical setting, I think past this point, industry needs to take over. And they have all the money that they can train this on 3 dimensions. But in terms of the first part, actually, let me just exit this so that I can quickly jump where we have to go. But in terms of the work that I was talking about, strain profiles and all, yes, eventually it's going to go to that point. For example, already in our lab, we are looking at if we are placing transducer, for example, at 90 degrees, what sorts of neural response are we recording in mice? And obviously, next step from that is to do human trials. Already, we are doing some human trials with acoustic radiation force imaging, but to study the effect on, for example, things such as depression, anxiety, addiction, those are coming. Those are definitely coming. We specifically don't have plans for those just yet, but those are up and coming. Actually, right now, last I checked on government's website, there are over 50 clinical trials using transcranial ultrasound for just very different things. I mean, the interesting thing is because no one actually really knows what's happening, it's the Wild West. Everyone is trying different things on different conditions, hoping that they will get some result out of it. So there are lots of human trials. We will be doing some, but not for the deep learning part just yet, because that's in 2D.
Mm. Okay, thanks. That's another question. No more question.
And
Okay.
I'm also happy to share my email. I'll send it to Thomas afterwards. And if anyone wants to discuss further, I'm more than happy to stay in touch and talk further.
Okay. Okay, guys. Again, thank very. I like this work. So, for curiosity, I have a curiosity. You have alguna comparación on another works, for example, the propagation in homogeneous medium, in non-homogeneous medium, for example?
The question was propagation in non-homogeneous medium?
Yes.
Yeah, so I have not looked at in homogeneous medium or heterogeneous medium, because when we are doing these simulations, we make this assumption that the brain matter for the most part is homogeneous.
Mm.
That is not exactly true, though. I have to mention that there are differences in mechanical properties of different parts of the brain,
Mm-hmm.
and also across different patients.
Yeah.
But for first order approximation, it is a safe approximation to say that it is homogeneous. One thing I will show is that, I mentioned in this part of the talk, for example, in this slide, I said, well, if you just place the transducers at 90-degree angle with one another, you're going to be able to improve the spatial resolution by 40-fold. And I talk about deep brain, but note that this is only 30 millimeter away from the transducer surface. So this is, of course, not deep within the brain. The reason why I ran these simulations was that we wanted to show that with 1 megahertz, you can reach 0.24 cubic millimeters, sub-cubic millimeters. Now, if I'm running my simulation at such high frequency, let's say 1 megahertz, I have to also make sure my grid resolution for simulation is very fine, right? I want to pack, for example, at least, say, 11 or 12 spatial points within each wavelength, so I get an accurate simulation. But I didn't have the compute power to be able to run a 1 megahertz simulation for, let's say, a 10 centimeter wide simulation field to show what happens transcranially. But that was a question that reviewers asked us for this paper, and said, well, what is the guarantee that this is going to hold if you're doing it with the skull present? To answer your question, heterogeneous medium.
Yeah.
So I ran a separate simulation with them to prove to them that we still can do this. So here's actually another simulation to show you. What I did in this case was I reduced my frequency to 250 kilohertz, so that now I had to, for example, only sample 5 points or so for my wavelength, 5 or 6 points, and that would be sufficient. And we show that in this case, so in panel A, again, it's a single transducer. I don't know if you see that pink sliver I have on the left. That's to represent the transducer. And you can see we have some internal reflections from the skull, some standing wave, and so on. And then in panel B, we put 2 of those transducers facing each other. And we have this 700 cubic millimeter, roughly, target volume. But in panel C, when I place 2 transducers at 90 degrees, now all of a sudden we go from 703 down to 26 cubic millimeters. So this was my way to prove to them that even in heterogeneous media, where you have the skull, if you have done phase aberration correction properly, you can still hugely optimize. I think this was like a 43-fold improvement, if I remember correctly, in terms of your spatial resolution. But again, ideally, what we want to be able to do is to be able to do this with 1 megahertz with humans. I just can't run the 1 megahertz simulation accurately enough for this kind of a large simulation field. That's the problem. But thank you so much for that question. I was hoping someone would ask so I could show this in a new slide.
No, it's okay. I thanks class. Everybody Un applause for you.
Thank you very much. Thank you so much for this opportunity. Thanks again, Marcelo, for inviting me to give this talk. It was an honor. Thank you very much.
Okay. Well, is the
Thank you
end?
very much for you. I think that there is a question in the chat, Humberto.
Another question?
Yeah, it's
Yeah.
Vladimir wrote a question in the chat.
Okay, I'll check.
No.
Yeah, Vladimir, thank you so much for the question. So that temperature rise is actually, yeah, great question. So in my talk, I only talked about neuromodulation. And the intention there is how can we interfere with the way neurons are firing? And either we want to repress them or we want to excite them, right? Stimulate them, one way or the other. To do that, we always keep the intensity low enough that we don't raise the temperature beyond critical values that we're going to burn the tissue. There is another thing that transcranial focused ultrasound is being used for. In fact, that which is for ablation, to actually burn the tissue. And that one has already received approval from the FDA. I think every Friday at Stanford, we have patients who come in for essential tremor, and we treat them by exactly raising the temperature so much at the focus that we are burning it. So these patients, I don't know if you're familiar with it, essential tremor is essentially this like tremor in the hand, which is so bad that we give these patients a cup of water to drink. By the time they bring the cup to their mouths, like half the cup is empty. Water has splashed everywhere because of the tremor in their hand. What we do is that we put them inside the MR scanner. We give them this helmet transducer. It has 1,024 elements, transducer elements. We do all of these things that I talked about. We do the phase aberration correction and all of that. And we make sure all the 1,024 rays intersect at this specific part of the thalamus. And we increase at first we send very low intensity pulses, and we record the image using MR thermometry. The rise in temperature is something like 0.2 degrees Celsius, 0.4 degrees Celsius, and that is enough for MR to be able to pick out where the target is. Once the neurosurgeon is certain that the target is exactly where we want it to be, he asks the technician to up the intensity. Then we increase the intensity so much that we're actually cooking the brain, and there is no anesthetics, nothing. The patient is awake, the patient is aware of what's happening. And the whole thing takes about 30 seconds, 20 to 30 seconds. You cook the brain, then you pull the patient out of the MR scanner, and you give them a piece of paper to, like, there are 2 dots, for example. You ask them, connect this dot to that dot. They can draw a perfectly straight line after only like 20 or 30 seconds of sonication and burning that part of the brain. So that was pretty smart. Thank you for asking that question. We use it for different aspects, for actually burning the tissue and for neuromodulation. I only talked about the neuromodulation part of it, but thank you so much for that question. And by the way, did I answer your question completely? If I didn't, please follow up.
Okay. Okay, thank everybody. One, I finished our seminar today. Marcelo, you want to speak any word?
Yeah, I just wanted to thank Kasra for his very interesting work.
Yes.
We're friends from UCSD, and then Kasra went to Stanford, and he was telling me, updating me of all these very cool projects that they are doing in Stanford. So thank you very much for sharing it with our community. Our community is very math driven. So you already saw it, Kasra, in Humberto question.
Yes.
So I think that maybe there is opportunity to do something together eventually. So thank you very much.
Absolutely. Again, it was my honor. Thank you so much for asking me to give this talk. Thank you.
Okay. Oh, okay, again.
Thank you, everyone.
Thank you, everyone.
Bye.
Bye-bye.